Hi everyone, Dave Bosch here. I am doing a quick video on how to perform femoral artery Doppler during a resuscitation. I've recently covered this in an ultrasound workshop and there have been lots of questions about it, so I wanted to post a quick video. I know that I like to know during a resuscitation if my patient has a pulse. It's very useful. Obviously, we know that just based on experience, doing manual pulse checks can be time consuming and it's fairly inaccurate. They've recently studied this and show that the accuracy can be as bad as 66% when the systolic blood pressure is over 60 and as bad as 50% really for when they're detecting any pulse. And so by using Doppler ultrasound, you can look at this this quick little graph here and see that the numbers are much better for accuracy to detect a pulse or not to detect a pulse using ultrasound. So now this wasn't a huge study, but it's a fairly easy thing to do, and it's not super complicated and gives us, I think, a lot of useful information. And so getting to the procedure itself, first we want to have the ultrasound in the room. Hopefully you've already done this because you're running a code. And we want to use the high frequency linear probe, and ideally we want to have it on an arterial setting. Tom Califf made this little preset on his machine up at Summit, the arrest pulse check peak systolic velocity checker, and so that's, you click that and or a similar arterial and you will get into the right mode. And so this is what we want to see. We're going to use the linear probe over the femoral artery, kind of like if you're going to put in a femoral A-line or a femoral central catheter. It's going to be short axis, so you're going to see the round artery. And then we want to be using pulse wave Doppler, not color flow, which is what I think a lot of people have historically used to see, flow in arteries or veins. But we want to see the pulse wave Doppler. So you hit that PW button there, and you hit it one time, and what will happen is a gate will come up, and the gate is right here. And so on the screen, you can move that gate around. So with your maybe dominant hand, right hand, you're holding the probe very still, kind of centering it. With your left hand, you can touch the screen and move that gate right into the center of the artery. Do this during compressions, and you will be and you will start to see, especially if you hit pulse wave again, which is how you activate pulse wave Doppler, and you will hear and see large compressions going on, and you'll see this very tall spike in the pulse wave Doppler flow tracker. When compressions are stopped, this is when you're going to look for a tracing like this. And so again, you can see on the screen that we've got the gate right over the femoral artery, and we see pulsatile waveforms. The cutoff that we're looking for is 20 centimeters per second. So that's the peak systolic velocity. And so we want that to be over 20. That correlates with approximately 60 millimeters mercury of systolic blood pressure. And so this is very useful. Obviously, if you are doing compressions, you stop and you see a nice waveform, you can be fairly confident that patient has organized cardiac rhythm, they've got a pulse, and you can move on with your resuscitation. This takes probably around 2 seconds and is highly accurate, whereas pulse checks can drag on and on and on, where people hem and haw about whether or not they feel a pulse or whatnot. So doing this can alleviate some of that vague question about whether they have a pulse or not. And you don't need to actually measure this. It's just a visual interpretation of where the pulse peak systolic velocity is compared to that 20, which will come up on the side. So that's pretty much it. I think that one kind of interesting thing we can use this for is potentially guiding quality of CPR. This really hasn't been studied really aggressively, but just think about when you're doing CPR and you've got a really bad compressor versus when you got a really good compressor, right? We know that the better compressor is giving a kind of a higher compression quality. And so say you've got a Lucas on, or say you've got somebody that doesn't seem to be getting really good effective CPR. While they're doing the CPR, you can be measuring this and maybe have that person slide up or down on the chest an inch. and see if what you get is a better peak systolic velocity. There is something that that Tom Califf also had mentioned to me, and I think that it's again not well studied, but compression too high up on the chest can actually cause a LVOT compression and an outflow tract obstruction, so which is going to correlate to really bad CPR. By moving down an inch or two on the chest, getting down to the apex of the heart, it may release that LVOT obstruction and provide a lot better CPR. So you can kind of guide your compressors to where they should be on the chest, or slide the lucus up and down based on what you're seeing on the pulse wave Doppler waveform. So this is kind of what we call like an individualized CPR. Not everyone just gets just slam chest compressions where the heart is. We all know that some people's hearts, like in COPD, they kind of slide way down in the chest, and other people's in heart failure, they kind of bulk up into the chest, maybe go out laterally. And so I think this is kind of a nuance, but something to play around with, and I think could have some impact on some of your patients. Probably studies on this are up and coming. For now, I think it could just be something that you can hold in your back pocket. That's pretty much it, guys. We do have a couple useful articles that are out there if you want to just read up on this. The second one from EP Monthly is a half-hour video. They dive deep into this. But some of these are just kind of quick and easy learning points. If you have any questions, please reach out to me, and I will try to come up with an answer best I can. Thanks.